questions related to the ACR's clinical guidance for pediatric patients during the COVID-19 pandemic. My name is Jay Mehta. I'm the chair of the two task forces focused on the pediatric clinical guidance. Pleased to be moderating this town hall along with my colleague, Dr. David Karp, who's the ACR's President-Elect. Tonight's town hall is being recorded, so it can be made available on the ACR website later this week. At the time of registration for the town hall, members had the ability to submit questions about the clinical guidance documents. Many of those questions will be addressed during this presentation. You are also encouraged to submit questions throughout tonight's presentation using the Q&A box. We'll answer as many questions submitted through the Q&A box as time permits. My co-moderator, Dr. Karp, will be assisting in answering questions through the Q&A box in real time. However, we will not be taking any verbal questions during today's webinar, and your microphones will be muted throughout the presentation. Before I introduce our panelists, I want to provide some background on how we got here. To address the COVID-19 worldwide pandemic, the ACR Executive Committee formed two clinical guidance task forces to address the care of pediatric patients during the pandemic. These task forces included experts in pediatric rheumatology, pediatric infectious diseases, pediatric ICU, pediatric cardiology, and adult rheumatology. The clinical guidance documents produced by the task forces were approved by the ACR Board of Directors in mid-June. The recommendations provided are part of what we view as living documents. We recognize that additional data is evolving rapidly and there is an anticipated need for updates to the recommendation as new evidence becomes available. Manuscripts were also developed for publication and are now available in arthritis and rheumatology. The charge and guiding principles of these task forces were to develop clinical guidance for the care of pediatric patients in the context of COVID-19. The audience for these guidance documents are ACR members, pediatric rheumatology providers, pediatricians, and other pediatric specialists. The primary products from these task forces were to produce guidance documents that promote a standardized approach to the care of amidst the pandemic for both pediatric rheumatic disease patients, as well as children who present with MIS-C and COVID-19 related hyperinflammation. Just to keep in mind, these aren't traditional guidelines. There was not a formal review of the evidence, and these are what we were terming guidance documents. They're based on scant, but as we know, rapidly evolving evidence. Please note, these are not meant to replace your provider's best clinical judgment or the clinical judgment of the pediatric rheumatology providers or the other specialists mentioned, and should not replace shared decision-making with the patient and parents. It assumes that other best practices are in place, and the goal of these documents is to align with, but not duplicate, other ongoing ACR efforts. And just to bring your attention to, these are the two documents that were published in Arthritis and Rheumatology, and you can find these on the Arthritis and Rheumatology website. We're very fortunate. So first we'll talk about the MIS-C task force. We're very fortunate to not only have a group of pediatric rheumatologists, but also two representatives of the pediatric infectious disease community, two pediatric cardiologists, one pediatric ICU member, and two adult rheumatologists. And you can see the names and their institutions here. Now I'm pleased to introduce our esteemed MIS-C panelists. Dr. Lauren Henderson from Boston Children's Hospital, who is the lead author on the guidance document, Dr. Scott Canna from the Children's Hospital of Pittsburgh, Dr. Kevin Friedman from Boston Children's Hospital. Dr. Friedman is a cardiologist. Dr. Mark Gorelik from the Columbia University Vagelos College of Physicians and Surgeons, and Dr. Sivia Lapidus from Hackensack Meridian Health. I'll now turn this over to Lauren, who will provide a brief overview of the recommendations and address questions previously submitted.
Thanks so much, Jay. So our task force addressed inflammatory syndromes in children with SARS-CoV-2 infections. We felt that this could be grouped into two broad categories, MIS-C and hyperinflammation in COVID-19. And at this time, with the available evidence, we felt that these two entities could be distinguished and considered separately. So MIS-C is really characterized by children who are previously healthy. They tend to present late in the SARS-CoV-2 infection, so often in the third, fourth week, or even beyond. These patients present with fever, inflammation, and multi-organ dysfunction, and they have high rates of SARS-CoV-2 seropositivity. Hyperinflammation in COVID-19 tends to occur in children who are medically complex, and this often occurs in the second week of the SARS-CoV-2 infection, in the acute infectious phase that is often characterized by predominant respiratory involvement. And these patients are often at high rates SARS-CoV-2 PCR positive. Next slide. To address these conditions, our task force was subdivided into 4 working groups. This covered the diagnostic evaluation of MIS-C, cardiac management of MIS-C, treatment of MIS-C, and hyperinflammation in COVID-19. Each work group developed an evidence report based on the available published literature, clinical experience, and expert opinion. Each work group also developed preliminary recommendation statements. Then the entire task force reviewed these evidence documents and voted on the recommendation statements. Consensus was achieved using the RAND UCLA modified Delphi process. So each task force member was asked to vote on each recommendation statement using a 9-point scale. The 9-point scale was used to assess appropriateness of each recommendation statement. A score of 1 to 3 was considered inappropriate, a score of 4 to 6 as uncertain, and a score of 7 to 9 as appropriate. In addition, we looked at the level of consensus. A statement with high consensus occurred when the entire task force, all 16 members, their votes fell in the same tertile. Low consensus occurred when more than 5 votes occurred in the lowest tertile, and simultaneously there were also 5 votes in the highest tertile. All the rest was considered moderate consensus. A statement was approved and published in the guidance if it was rated as appropriate. It got a score of 7 to 9, and there was moderate to high degrees of consensus. After this voting, there were webinars to discuss these results and emails and further discussion for clarification. So tonight I want to touch on some highlights of the guidance. And as Jay said, more detailed information is published in the arthritis and rheumatology manuscripts. We want to have plenty of time for question and answers today, so we won't be touching on all aspects of our guidance. We also want to reiterate that a lot of this guidance was based on limited available published data, and these guidance and recommendations may change over time. It's also important as we go along in this discussion to remember that a vast majority of children with COVID-19 have mild symptoms and excellent outcomes. And from everything we know right now, we continue to believe that MIS-C is a rare complication of SARS-CoV-2 infections. The task force spent some time comparing and contrasting MIS-C to Kawasaki disease. In the literature, MIS-C is most frequently compared to Kawasaki disease. And this is because there are similarities between these two conditions, including the fact that patients are often febrile and have very prominent mucocutaneous symptoms. But the task force also wanted to highlight that there does seem to be differences between these two conditions, at least differences between MIS-C and historic Kawasaki disease cohorts. So there is a possible increased incidence in Afro-Caribbean and Hispanic patients with MIS-C, where KD seems to be more common in patients of Eastern Asian descent. The age range of MIS-C patients is much broader than that of Kawasaki disease. And patients with MIS-C present with more prominent shock, cardiac dysfunction, GI symptoms, and neurologic involvement. In addition, MIS-C patients tend to have lower platelet counts, lymphocyte counts, and higher CRP levels. At this point in time, it's very difficult to determine the difference in the incidence of coronary artery aneurysms in patients in MIS-C compared to Kawasaki disease. And that's because we don't fully know the full spectrum of MIS-C patients at this time. Next slide. For the diagnostic evaluation of MIS-C, the task force recommended a 2-tier approach. And the idea was that we would like to identify MIS-C patients, but we also do not want to subject children to complex and burdensome and expensive testing for every child who presented to the emergency department or the clinic with fever. So we elected to use a 2-tiered approach to reduce the need of excessive testing. In addition, it's important to understand that at this point in time, we don't really know the sensitivity and specificity of a given clinical feature in the diagnostic value of MIS-C. And so these recommendations for the diagnostic evaluation may change. If you look at this algorithm on the slide, the task force recommended that children who present with fever, an epidemiologic link to SARS-CoV-2, and suggestive clinical features be considered under evaluation for MIS-C. However, it's very important to emphasize that these patients really also need to undergo a diagnostic evaluation for other causes of the presentation unrelated to MIS-C, other infectious causes or non-infectious causes. In children who are stable, we recommended a tier 1 evaluation. This involves testing that's usually and routinely available at most clinical sites, including laboratory-based testing. After this first tier 1 testing, patients with high inflammation and suggestive laboratory features would go on to tier 2 testing, which is more complex, involves more complicated laboratory studies and imaging studies such as echocardiogram. The task force did feel that if a patient presented in shock and had life-threatening manifestations of MIS-C, those patients should undergo tier 1 and tier 2 testing. It's important to note that some patients with MIS-C may be able to undergo a diagnostic evaluation as an outpatient, as long as their symptoms are mild, their physical exam appears to be reassuring, and they are ensured to have good clinical follow-up. We also felt, the panel also felt that it's important that most of these patients will need to be followed by a multidisciplinary team that will help in the diagnostic evaluation and therapeutic management. Next slide. Now I'm going to briefly touch on some of the recommendations that we published in our guidance. Again, more information is available in the publications. For cardiac management of MIS-C, patients have abnormal BRP or troponin levels. They really should be followed until they normalize. It's important to remember that patients with MIS-C can have cardiac conduction abnormalities, so these patients will need EKGs and some might need Holter monitors. Given a prominent cardiac involvement, patients will need echocardiograms at diagnosis, and they will need repeat studies at 7 to 14 days after the initial presentation and 4 to 6 weeks later. Patients with cardiac involvement, they may need more frequent echocardiograms and may even need other studies like cardiac MRIs. Next slide. Regarding the immunomodulatory treatment of MIS-C, it will be important if a patient is relatively stable for that patient to complete the diagnostic evaluation before immunomodulatory treatment is started. In addition, some patients with mild symptoms may not require treatment. There are published reports in the literature of patients who were not treated for MIS-C who did well. However, we don't fully understand the risk of coronary artery aneurysms in those patients. In patients who are treated, we recommended a step-by progression of immunomodulatory therapy. First tier treatments included high-dose IVIG and low to moderate dose steroids. Some patients who present in shock or have life-threatening manifestations of MIS-C may need higher doses of IV pulse dose steroids. In patients with refractory disease, anakinra was recommended. The task force recommended that serial laboratory studies and cardiac assessment guide immunomodulatory treatment and tapering, and that patients often will need a taper of the immunomodulatory treatment up to 2 to 3 weeks or even longer. Next slide. For anti-platelet and anticoagulation therapy in MIS-C, low-dose aspirin was recommended, and consensus was achieved by the panel for MIS-C patients with KD features and patients with thrombocytosis or a high platelet count. In patients with MIS-C and coronary artery aneurysms, those with a Z-score under 10, it was recommended they be treated with low-dose aspirin, and those with Z-scores above 10 should receive low-dose aspirin and therapeutic anticoagulation. The task force achieved consensus that MIS-C patients with thrombocytosis or a low ejection fraction should receive therapeutic anticoagulation. Next slide. Now, on this last slide, I'm going to switch gears and discuss patients with hyperinflammation in COVID-19. Again, these are the patients who are often medically complex, present in the initial acute infectious phase of the disease with prominent respiratory symptoms. In those patients who have signs of ARTS, shock, and very substantially elevated inflammatory markers, the task force reached consensus those patients should be considered for treatment with immunomodulatory therapies. In those patients, the treatment options included glucocorticoids and anakinra. Tocilizumab could also be considered, but the task force did recognize that there seems to be a possible associated risk of higher infections, bacterial and fungal infections in patients treated with tocilizumab. And these are our summary of the guidance provided by our task force, and we'll now switch gears to questions and answers.
As we mentioned at the outset, registrants had the opportunity to submit questions, and so we'll first start with some of the questions that were submitted. For this first set of questions, I'll ask Mark and Sivia to answer these. So how broad is the spectrum of MIS-C? Are there patients with MIS-C with mild disease? Do all patients with MIS-C have fever? And can you have MIS-C without fever, GI symptoms, or mucocutaneous features?
Thank you. I'll take the first one. How broad is the spectrum of MIS-C? It does seem to be a broad spectrum in that some patients present with severe shock, hemodynamic instability, even requiring ECMO with severe cardiac sequelae, and some present with the features of MIS-C on the other end and require observation, which is why we changed our two-tiered approach so that we would not overtreat and observe patients as we follow them. Perhaps, Mark, you have other comments on that question?
No, I think everybody's going to have a different view based on sort of their perspective and their experiences. But I think, yes, it's broader than we appreciate. Like you said, I agree. Some kids are definitely not presenting in shock, and so. But I think that and it depends on what you define as a MIS-C. I think one of the common features for us was the presence of myocardial irritation or injury, and that was a common theme throughout that. So, and then we were gonna sort of discuss also, patients with mild disease, and I think that really depends what your definition of mild is. I think if mild is a suggestion that the patients may be able, to be not even admitted, they're doing well as an outpatient, and they may have been missed. I don't think that's the case, and we're trying in our own institution to kind of look through all of our outpatient clinical visits during that period of time, and we actually didn't see anything. We're sort of trying to compile that. But I think if you mean mild as in not in shock, patients who might have persistent fever, not in shock, then yes, that does exist. And then I think, in my opinion, and Sivia may have we may differ on this, but I don't think that patients with MIS-C, I think all patients with MIS-C do have fever. And I think that's a sort of a defining characteristic, and I think it would be very hard to make a diagnosis of MIS-C in a patient without fever. It can become very, very tricky, and worry about overdiagnosis there.
I do agree with that. Absolutely, fever is required as far as we know now, and all the criteria speak to that as well. The WHO, the New York State Department of Health, and the CDC criteria all require fever. I will say that the current publications and experience is more with hospitalized inpatients. So there may be a cohort of outpatients that we're not capturing in pediatric rheumatology or in the hospitals. Another point is that I do agree that we cannot have MIS-C without fever, but although the majority of patients do have gastrointestinal symptoms, it is conceivable to not have gastrointestinal symptoms, and it is also conceivable not to have mucocutaneous features. The CDC did define different classes of MIS-C with somewhat of a different phenotypes in terms of the broad spectrum, some of whom have more features of respiratory features of COVID-19, some of whom were more reminiscent of what we think of as historic Kawasaki disease, and some of whom had primarily shock and GI symptoms.
I think that class 2 and that CDC guide sounds to me like infection, and so I would worry about that as being whether that really is MIS-C or not, because I don't think that we saw, and I doubt you did either, any really MIS-C that had significant respiratory component.
Yes, That is true, and sometimes it's as subtle as a chest X-ray abnormality that's not symptomatic. So it's hard to know if that's lingering from prior illness or not.
Why don't we go to the next slide? So the next set of questions, and I'll just remind the audience that if you have, we won't be taking questions verbally, but if you have questions, you can put them into the Q&A box on your screen. So Sivia, maybe you can speak to this. What is known about MIS-C in infants? Is the incidence of MIS-C different in this population? Do infants present with different symptoms? And what are the risk factors for severe disease in infants?
Excellent and very challenging questions, so I'll try to tackle them. What we know now about MIS-C in infants is very little. The majority of series in the literature do not describe infants as being involved in the interquartile ranges of age, typically do not include the infant age group. There is some data in the New England Journal of Medicine publications about infants, and it comprised about 8% of the population in the national cohort of 186 patients. In the New York State cohort, it was comparable in terms of the number of patients, infants with MIS-C. In terms of the CDC has also commented on the most recent update of somewhere in the scope of a little under 600 patients. There were also about 8% of infants affected. In our own hospital's cohort at Hackensack Meridian Health Network, we had interestingly, we had about 25% of patients admitted for pediatric COVID-19 were infants. And interestingly, only 8% were infants with MIS-C. Although many centers, I'm sure, have not seen MIS-C in infants, and it may be a very hard entity to properly diagnose in infants. Is the incidence different in this population? Definitely, as discussed earlier. And do infants present with different symptoms? What is described, which is minimal, is that infants are more likely to present with features reminiscent of Kawasaki disease. And interestingly, the infants tend to be less ill. Unlike classical Kawasaki disease pre-COVID, there does not seem to be, in the small numbers, an increase in coronary aneurysms, and they seem to have less myocarditis or cardiac damage than the older cohorts that are more likely to present in shock and with higher acuity. So in terms of what are the risk factors for severe disease in infants, probably we don't know. We do see an increased signal in pediatric COVID that infants tend to have underlying medical conditions such as genetic diseases, metabolic conditions, and congenital heart disease. But I would venture to say that there have not been enough infants to stratify risk factors. Thank you.
David, were there any questions? Have there been any questions in the question answer box?
Yes, there have. A couple of them have been answered already, but I just want to make it clear to folks that this is being recorded, and the recording will be available later in the week. The ACR staff will put it up on in the COVID-19 section of the rheumatology.org website. So we have a couple of questions about treatment. And I think we're going to get to some of the ones about IVIG in a few minutes, and we'll save those. But I'd sort of like to hear the answer to this about are there known cases of fatal MIS-C?
Lauren or Sivia, do you want to take that one?
So I think that in the chat box, Kevin has also answered. So the CDC has reported about 10 deaths of 570 reported cases. In addition, in the literature, the New England Journal of Medicine article published about the experience in New York reported on 2 cases of fatality, which, Mark, I don't know if you can speak to at all. So there do seem to be low numbers in the larger cohorts, range around 2 to 3%.
Right. I only am aware, and this is from somebody who was working with the New York Department of Health, that those 2 children were not treated actually with steroids and IVIG, and we don't know much more about them. That's kind of the sum total of the data of those 2 kids in New York that passed away.
And as I said, we're going to come to IVIG in a minute. So there's a number of questions that people have asked. Why don't we save them up for after that section and see if they get answered.
Great. Why don't we move to the next slide? Kevin, can you talk to us a little bit about what's the role for anticoagulation in MIS-C and what's recommended for anticoagulation?
Yeah, so the role of anticoagulation is evolving, and there's no hard evidence on any of this. We do know that patients with MIS-C are quite hypercoagulable based on their laboratory findings, very high D-dimers in many cases, thromboelastograms showing platelet activation, so certainly at risk for thrombus. The CDC paper that was published in New England Journal reported 4 venous thrombosis events at a 2% rate. I'm not aware of any of the other studies publishing it, thrombosis rate. So while we know these patients are at risk based on their labs and certainly the adult experience, it seems like the risk is actually, we are not seeing a lot of clinical events. That said, there's still a lot of concern about how to anticoagulate these patients. I think it's pretty clear that patients who have either coronary artery aneurysms or significant ventricular dysfunction, like an ejection fraction less than 35 to 40%, they would be anticoagulated if they had any other disease process. So they clearly should be on anti-platelet as long as they're not thrombocytopenic doses of aspirin and probably systemic, either Lovenox and then perhaps later on something like apixaban. What's less clear is what to do with all the patients who have normal coronaries and relatively normal function, but quite abnormal coagulation profiles. And that's been often institution dependent. A lot of institutions are using D-dimers to stratify risk for thrombosis and giving at least a prophylactic or therapeutic heparin or Lovenox for patients with quite high levels. And others are giving aspirin for all patients who are not thrombocytopenic. So I think that's an evolving topic, but certainly one worth following.
Next slide, please. Lauren, can you tackle these? When should IVIG be used to treat MIS-C? When should steroids be used to treat MIS-C? And when should both be used?
So I think in a way, this is a difficult question. So if you look at the case series that have been reported on MIS-C, IVIG and steroids are really the most commonly used treatments in MIS-C. But it's important to recognize that there have been no comparative studies comparing IVIG and steroids. And so it's very difficult to speak to if one approach is superior to the other, or if we should be using both. Based on our discussions as a task force, the use of IVIG is really based on the efficacy of this medication in preventing coronary artery aneurysms in patients with KD. It's also important to note, as Sivia mentioned, that there are multiple reports in the literature of patients who did not meet KD criteria who developed coronary artery aneurysms. And for that reason, in general, we've been using a low threshold for giving IVIG to MIS-C patients. Regarding steroid use, this is really based on reports in the literature that patients with MIS-C have a high level of steroid resistance. So they often continue to have fevers and symptoms after that first dose of IVIG. And so this is in the Italian case series that was reported in the Lancet. They had 50% IVIG resistance. In the recent COVID cohort in ARD, this was over 60%. And so that's the rationale for using steroids even up front. Certainly in my institution's experience, if the patient is in the ICU and sick, they often will get low dose steroids starting at 1 to 2 mg a kg a day. If patients are more severely ill, requiring multiple pressors, these patients will also often get high dose steroids at other institutions with IVIG. And so that's the information that we have available right now. Hopefully in the future, we may have more comparative literature to help us evaluate one way versus the other. I was trying to read the chat while I was answering these questions, and I know there were some questions about how do you manage IVIG and fluid overload? Kevin, I don't know if you want to speak to that a bit.
Yeah, so I think it's an issue in a few ways. One is that a lot of these patients, unlike most Kawasaki patients, can be quite big. These are older patients often, and in many cases they're actually overweight or obese. So I think we haven't always given the full 2 grams per kilogram. We've often capped it at something like 70 grams, or even given it in divided doses if we're worried about ventricular function. I think the patients you have to worry about are those with significant ventricular dysfunction, so ejection fraction at least less than 45. Most of the kids with higher ejection fractions, which is the vast majority of MISC patients, will tolerate the volume load well. You can either divide it up or just give it a little bit more slowly, or if they're hemodynamically fairly stable, but fluid overload, a dose of Lasix is completely fine for most of these children if they need it. But I think just giving it slowly and not giving a full 2 grams per kilogram, especially in the very large older kids, is probably reasonable.
Why don't we go to the next slide? Mark, can you speak to when should biologics be used for MIS-C and what biologic agents are recommended for MIS-C?
Sure, and I think that it's hard to say that this is a should question. It's an experience, and as rheumatologists, I think we all know when our patients are not responding to therapy and when they need extra therapy, and so it's in those kinds of patients, and in our experience, basically patients who we've had a few, not many, a handful, who are, IVIG resistant to a second IVIG and really steroid resistant, continue to have fevers throughout. And in those patients, we have used anakinra, and it's been very helpful to really get rid of the, fever and get rid of all those symptoms, and as well as kind of decrease the inflammatory laboratory features. So that's that situation. In terms of what biologic agents are recommended, we again used anakinra, and I think we used anakinra from the rheumatologist view of fever and as being an IL-1 mediated process. There is a very, very small series of patients that was published in New England Journal of Medicine using tocilizumab for Kawasaki disease, which showed not very promising results, but again, it's really hard to know what to draw from that. And then there's a group that's been using infliximab as well, and I think that they have been doing fine. So, I think it's tough to say what would be recommended. I think when to use it is obviously when your patients are just not responding to first-line therapy. And we again use anakinra because it's easy, it's easy to dose, and feel comfortable with it. But I don't think it's wrong to use tocilizumab or infliximab if that's a choice.
Can we go to the next slide? David, were there other questions?
Well, there are a couple that actually sort of go back to the previous section, maybe about diagnosis. And there's a question about how long a period after exposure would you consider for MISC diagnosis?
Sivia, would you want to speak to that?
Sure. The average time typically of COVID exposure to MISC that we know about is around 3 to 4 weeks, usually around 25 days. So that's what we know thus far. It's hard sometimes to definitively know when the COVID exposure was, which is the challenge in a lot of these patients. But just to comment that many of these patients are either SARS-CoV-2 PCR positive or have positive serology, so that's helpful as well.
And there's a question about whether there are laboratory parameters that you might use for adjusting anakinra dosing.
Mark, do you want to take that one?
I think you can follow, if you wanted to, I think you could follow their CRPs. You will know, that the anakinra is working symptomatically, though. I think that they will, very quickly stop having fevers and look much more comfortable. But in general, I think following CRPs is useful to sort of know that your patients are responding. And again, in a handful of patients, we've had refractory, persistent inflammation despite IVIG and steroids, and you can see that on the CRPs, and they definitely do respond to anakinra when that's needed.
And to follow up on that, is there a recommended duration for the treatment with anakinra, past the time maybe when the CRP normalizes? So
we did 14 days of anakinra, but I don't know that there really is. That's a very tough question. So I think I would continue it until the CRP normalizes, and I think you're fine at that point to then put them on a steroid taper after that.
Okay, and a question about if a patient has no cardiac or coronary involvement, is there any role for just using steroids alone and avoiding IVIG?
Lauren?
Oh, that's a tough one. I think my default is to use IVIG for the milder patients, just because we don't understand the risk for coronary artery aneurysms. So there's certainly some patients at our institution that we've treated that were relatively mild, met criteria for MIS-C, had a clear SARS-CoV-2 exposure that were treated with IVIG. And I've tended to reserve steroids for the more severely involved patients, so kind of the reverse. I'd be interested to hear what other people on the panel would think, because I think there's just no evidence to guide us on this here.
One thing that's important to note is that the cardiac involvement can evolve in some cases. So although most patients who are going to develop aneurysms or dysfunction present with such, there are definitely cases of even large aneurysms that have developed later on. Not that we know for sure that IVIG presents that, but I wouldn't say presentation without cardiac involvement guarantees lack of cardiac involvement over the hospital course. And certainly the IVIG experience with KD would suggest that it may be helpful, but we don't have evidence yet for sure on that.
And what would you expect the duration to monitor for aneurysms? No, it's hard to tell.
Yeah, I think largely based on the KD experience, if you don't have any evidence of aneurysm at 2 weeks, it's extraordinarily unlikely to develop an aneurysm.
So Kevin, when you say no evidence of cardiac involvement, do you mean that they have a completely normal NT-BNP, they have no mechanical dysfunction, their EKG is normal, etc.?
Yeah, so I would throw out the BNPs unless you're using a high cutoff value. So the BNPs are a little bit confusing because a lot of labs use a cutoff value of like 100, which you can get a elevated BNP with pretty much anything at that level. But yeah, elevated, I would count elevated troponin, significant EKG abnormalities like heart block, which has been reported, ventricular dysfunction, or aneurysms as major cardiac involvement. So
yeah, and I think it's for my own experience was that every patient that had this really did have sort of a sustained and some sort of marker of cardiac dysfunction, and skyrocketing BNPs or a mechanical dysfunction or something else. And I guess the question that I don't know the answer to this question, but is if somebody really has no sign of cardiac involvement, A, is it MIS-C? I'm not sure. And B, what are we treating if they don't have any sign? And so I don't know whether that's something to watch or that's something to treat with IVIG. I don't know the answer, but I think it's an important question.
Okay, and maybe one last question, which is sort of an interesting one about the role of anti-interferon gamma, imapalumab. Has anybody thought of that or put that into a trial situation?
Scott, can you speak to that?
Not intelligently. I am not aware of any experience in MIS-C with imapalumab. Certainly the experience in HLH and MAS is expanding, and at least in our limited experience, fairly positive. The biomarker evidence for the use of imapalumab in MIS-C and in acute COVID is not as strong as it is in patients with MAS and HLH in terms of the CXCL9 levels. Certainly they're elevated, but not to the same levels that we see in diseases where imipelimab is being actively studied. So I would say, given how well most MIS-C patients respond to other agents, I think that it's going to be fairly far down the line. But I don't know of any actual experience.
All right, why don't we go to the next slide? Scott, can you speak to these? How long should patients with MIS-C be treated with immunosuppression, and does treatment duration vary by disease severity?
These are good questions for which there are not data. I think one of the big open questions that I think we're all waiting for are some of the longer term data now that we have several months out from these patients. I polled our group of experts earlier today to see what folks have been doing, and there was some consensus around not tapering, especially steroids, too quickly. And I think Dr. Cron mentioned in the Q&A that had been his experience as well, that if you wean steroids too quickly, rebound is not uncommon, both in terms of systemic inflammation and potentially in terms of cardiac dysfunction. So, our limited experience has been that we were tapering steroids over a period of at least 2 weeks after the normalization of CRP. How people were tapering steroids or switching from IV to PO while patients were still inpatient was largely, roughly based on the improvement of their clinical parameters. So, along those lines, yes, treatment duration is going to vary based on disease severity, largely because the more severe patients are going to have a longer period before they show, substantial and stable clinical improvement. But the practice patterns are pretty wide. Overall, I think people have been pleased with outcomes despite the practice variation. But yeah, I think that especially for steroids, the wean has been on the order of at least 2 to 3 weeks, and in many patients longer. What gets weaned first has also been somewhat variable and largely depends on availability. In Canada, we hear reports of having easier access to getting patients on anakinra, and so they've been weaning steroids first. In the US, for largely coverage reasons, I think people have been keen to get patients off of anakinra while they're inpatient and then wean steroids as an outpatient. Overall, I think experiences have been positive in both directions.
All right, let's go to the next slide. How long should patients with MIS-C be followed? What labs should be used for monitoring? What are the recommendations for long-term cardiac surveillance? Lauren and Kevin, why don't you take these on?
Okay, I can start first. So we have actually been following patients, especially patients who are kind of classic patients in the ICU who are quite sick. Those patients were often sent home with a close laboratory monitoring plan. So Kevin will get into the echocardiograms, but they were often followed with 1 week with an echocardiogram and laboratory studies. And based on those laboratory studies, we would continue a steroid wean. And so often these steroid weans would take 2 to 3 weeks, or sometimes if the patients were not responding as well, even longer, 3 to 4 weeks. And we routinely monitor things that are abnormal in patients with MIS-C. So complete blood cell counts, liver function tests, coags, CRP, ferritin, those types of laboratory studies. In my experience, I found that the ferritin and LFTs took quite some time, and even the D-dimer to normalize, that often the CRP was a good marker to guide your steroid wean and how you follow these patients. And that I use CRP mostly to guide my steroid wean. Kevin, I don't know if you want to talk about your long-term cardiac surveillance.
Yeah, so because the natural history of both aneurysms and dysfunction are not, as well as heart block, are not entirely clear in this disease, we've recommended follow-up for, at a minimum, at 1 to 2 weeks with EKG and echo, and then 4 to 6 weeks, and then changing your follow-up plan for cardiac involvement depending on what is developed in that acute phase. And some of these children, if they've had significant dysfunction or aneurysms or heart block, we would follow them more longitudinally over a year. A minimum of at those follow-ups would be EKG and echo. Patients who had dysfunction, we're still trying to better understand the etiology and nature of the apparent myocarditis. We don't have any biopsy data, but cardiac MRI has been starting to be used in these patients to better understand the myocardial tissue characteristics. So that is one option as well.
All right, let's go to the next slide. Scott, can you speak to the role of JAK inhibitors in MIS-C and hyperinflammation in COVID-19?
I'm on a roll. Again, not intelligently. Again, I'm not aware of anyone who has received JAK inhibitors for MIS-C. JAK inhibitors, and most specifically baricitinib, many people will know, are quite encouraging and very, very preliminary data in severe COVID-19 in adults. Again, I'm not aware of any use of those in children. The rationale there being twofold: that baricitinib is going to be inhibiting, the signaling of the cytokines that are part of the cytokine storm, and certainly JAK1/2 signaling is important for a number of things that have been implicated, both interferons and IL-6. And there may be some evidence that baricitinib, through some non-JAK off-target effects, may inhibit the endocytosis of actual viral particles, so having a direct antiviral effect. This is all in vitro, and so the studies are ongoing, again, in adults with severe COVID, as to whether there's a real worthwhile effect of JAK inhibitors. And I think we've all seen the difference between the early preliminary favorable results and then the clinical trial results maybe not looking as favorable. So we'll just need to keep our eyes out. But again, like imapalumab, I would probably reserve JAK inhibitors for much further down the line. And I would further note the presence of, viremia, especially in adults on JAK inhibitors, varicella reactivation at a higher rate, and in children on JAK inhibitors, especially baricitinib for interferonopathies, BK virus, both viruria and viremia. So for that reason, in acute COVID, I think I'd be a little bit concerned, especially until we have some of those clinical trial data. In MIS-C, it may work, but I think that we have other agents with which we have a bit more experience that I would go through first.
David, were there other questions in the Q&A box?
I think that Kevin was going to answer one of Dr. Cron's questions.
Which one was that? Sorry.
The question is, for COVID-19 pneumonia that improves, but patients who develop thrombocytosis, do you use low-dose aspirin?
Yes, I sure would. For the anti-platelet effect, I think the bleeding risk is really low, and we know these patients from the adult literature and from our own work looking at thromboelastograms have very activated platelets. And although fortunately there haven't been a lot of reported arterial venous thrombus, they're certainly at risk.
And I think there's a question, but I think that we've sort of gone through it, and that's the lineup of agents for MIS-C, how we would place different biologics, different agents, and it's pretty much IVIG, steroids, anakinra, tocilizumab, and then other things. So I think that's if I'm not correct, please correct me. Then sort of an interesting last question, I think, is has anybody previously seen anything resembling MIS-C in an infection other than COVID-19?
I'll open up to any of our panelists for that.
We had a string of adenovirus that looked like this, I want to say 6 months ago or 8 months ago at our institution and at yours, Jay, at CHOP. We had a number of patients who had shock, some heart failure, a lot of systemic inflammation. with adenovirus. I'll say those patients didn't turn around as quickly. But I don't know that the MIS-C syndrome is so unique. It's, I think, more unique in its epidemiology.
Yes, we've had Pseudomonas bacteremia present with a phenotype of MIS-C, and also I think it's confusing group A strep. If it's group A strep and COVID exposure in the same patient, that could be very complicated.
Yeah, some other people are commenting on things like murine typhus here in Texas. I've not seen that, but I guess that has existed with MIS-C. Okay, that's about it, Jay.
Okay, well, I really want to thank our MIS-C panelists, Dr. Henderson, Dr. Canna, Dr. Friedman, Dr. Gorelik, and Dr. Lapidus. Thanks so much. We're now going to turn to the COVID-19 clinical guidance for pediatric rheumatology task force. And so similarly to the MIS-C task force, we were very lucky to have a diverse representation, including 8 pediatric rheumatologists, 2 pediatric infectious disease physicians, and then 1 adult rheumatologist. And you can see the members of this task force on this slide. So I'd like to introduce our esteemed panelists for this section. So Dr. Don Wahezi from the Children's Hospital at Montefiore, who led this task force. Dr. Kevin Downs from Children's Hospital of Philadelphia, who's an infectious disease specialist. Dr. Mindy Lo from Boston Children's, and then Dr. Sarah Ringold from Seattle Children's. And now I'll turn it over to Dr. Wahezi.
Thank you, Jay, and thank you, Lauren, for that excellent overview on the MIS-C document. So our task force was charged with providing clinical guidance to providers who care for children with pediatric rheumatic disease based on review of the currently available literature. Similar to the MIS-C task force, we developed clinical questions based on queries from patients, families, providers. We then divided the questions into 3 subgroups to review the literature and develop our evidence report. The subgroups focused on general risk assessment and prevention, recommendations for patients with pediatric rheumatic disease in the absence of exposure or infection, then recommendations for patients with pediatric rheumatic disease in the setting of either a close household exposure or an active SARS-CoV-2 infection. So similar to the MIS-C group, what you heard from Lauren, we also used the RAND UCLA modified Delphi approach to build consensus. We had 3 rounds of individual asynchronous voting and used similar numeric scales. We additionally held 3 webinars to discuss the votes and any areas of uncertainty. Several questions ended up being excluded due to lack of evidence or just really high levels of uncertainty. Others were combined due to common themes, and ultimately we ended up with 27 final guidance statements. So we'll refer you to the manuscript for the details surrounding the guidance statements. However, briefly, our guidance statements focused on general preventative measures and minimizing community exposures while really emphasizing the importance of continuing essential clinical care such as routine childhood vaccinations, assessments for uveitis, and mental health screening. When discussing patients with pediatric rheumatic disease in the absence of SARS-CoV-2 exposure infection, the overarching theme was really the emphasis on primary control of the underlying disease, emphasizing a continuation in the current medications or initiating medications as deemed necessary to control the underlying disease. We additionally discussed that special considerations may need to be taken into consideration surrounding steroids, recognizing that higher doses of steroids have been indicated as a potential risk factor for COVID-19. With regards to ongoing treatment in the setting of a close household exposure to COVID-19, and that is defined by the CDC as an interaction with a person known to have COVID-19 for more than 15 minutes at a distance of less than 6 feet without masking of both parties. So in that setting, our task force again emphasized the importance of controlling the underlying rheumatic disease. Again, in the absence of data suggesting that there's an increased risk in the setting, we recommended continuing current medications to really control the underlying disease. And again, with special considerations around steroids to try to minimize exposure to high-dose steroids during this time period. And then finally, stemming from our current practices surrounding infections and febrile illnesses in children with pediatric rheumatic disease, and in the absence of robust data related to active SARS-CoV-2 infection in this patient population, our task force agreed that current medication should be held in the cases of symptomatic COVID-19. The exceptions to this were patients who are on IL-1 and IL-6 inhibitors, recognizing that these medications are used in patients who might be particularly sensitive to medication disruption, such as those with autoinflammatory syndromes, and also recognizing the potential role of these agents in COVID-19 related hyperinflammation. So with those, we thought that those could be continued. With regards to asymptomatic COVID-19, we wanted to address this particularly in children, as we know that there are many reports of this in children, and particularly now that there's more screening prior to procedures and various things. We wanted to make sure that we also address this. And we came to consensus that medications could be continued in these patients. Again, just lacking evidence suggesting that there would be any harm to them continuing them, just provided that they remained asymptomatic. If there was any evidence of any kind of symptoms related to COVID-19, then again, we would hold the medications. So I'm going to hand it back over to Jay to help moderate the questions.
Yeah, so just as in the previous section, we'll be addressing some of the questions that were submitted beforehand, but if folks have questions, they can put them in the question and answer box and we'll try to address them during this. So for this first set of questions, we'll ask Kevin to provide some guidance on general recommendations for children with pediatric rheumatic disease to return to school.
Well, thanks. That's obviously quite a big topic to try to tackle in a shorter period of time. And I think it likely could be its own town hall. But just to briefly kind of summarize how we think about it from the infectious disease standpoint. Questions about return to school are obviously very difficult but important to answer right now. And given the significant variability in community transmission across the country and variability in resources, it's difficult to give a single answer. So I want to just briefly start by saying that there's no one right answer to that question for all children with pediatric rheumatic disease. Additionally, as a task force, this was not a topic that we specifically addressed. So this is more, I'll put it in the framework of children to return to school more broadly than address specifics in regards to rheumatic disease. We'll talk about kind of higher risk patients. So when thinking about return to school for any child, we can really think about it in three primary areas. First, it's the patient. So these are questions about patient-specific factors that might affect their risk for severe infection. Right now, we have not identified any risk factors associated with acquisition of COVID in children. But there are factors that may influence whether a child would be more or less likely to develop severe COVID disease. For pediatric rheumatic disease, those would be factors such as the degree of immunosuppression that a child's on, their underlying disease activity, as well as additional comorbidities that are present. And I think that last one is important to recognize, that the comorbidities that have been identified in all children are also more likely to occur in patients with other more chronic illnesses. So for instance, a child who's recently had a disease flare that's requiring significant immunosuppression, that might not be the right time for them to return to in-person school, whereas a child who's been on stable immunosuppression is likely able to. And so far, at least based on current data, we've not found that children on low or even moderate amounts of immunosuppression are at higher risk for severe COVID. And so I think we do want to try to encourage children to go back to school. There are certainly benefits to in-person education. But the other piece that has to play into it is the amount of community transmission and the public health responses that are in place locally. Clearly, there's going to be differences in terms of the risk of encountering a case of COVID in a school based on where you live right now. And so that also needs to play into the decision-making process. For areas where there's increasing numbers of community transmission, I think that we need to be a little bit more cautious with our higher risk children. And then the last area that I think is important to address for higher risk children are the infection prevention measures that are implemented in the school. We continue to talk about the same things, social distancing, masks, hand hygiene, and those are extremely important in the school setting as well. The CDC and the AAP have guidelines that have been published, and the degree to which various schools are going to implement them and will adhere to them over time might vary. So I think there's a few important, at least minimum steps that we should be considering for our higher risk patients. First, in terms of social distancing, I think for higher risk patients, it's important that they adhere to those measures of at least 6 feet, at a minimum 3 feet apart in the classrooms or when they'll have prolonged contact. If you're in a school setting where that can't be ensured, then I think having face coverings is particularly important. If face coverings are worn by all students, then cloth face coverings are probably enough. But if kids are not going to be wearing face coverings and you have a higher risk patient, then I think it's important that they themselves wear a surgical mask. Not an N95, but a disposable mask, or at least a face covering with a shield, if other kids are not going to be taking measures to prevent spread to them. And then additionally, obviously hand hygiene is important in cleaning and disinfection practices. But lastly, what I encourage families of immunocompromised patients to do is to discuss what are the sick day policies in the school. What's going to happen if there's a sick child in the classroom? What steps are being taken to prevent sick teachers from coming to school as well? And if there are not provisions that are clearly outlined and you have a higher sick child, then that needs to be weighed pretty heavily. I also encourage students that do need additional measures in the school to try to discuss IEPs and 504 plans and individualized health plans with their schools. So all in all, I think it's not a one-size-fits-all answer to that question. We certainly want to encourage kids to return to school. I think all parents are struggling with these decisions right now. But when we take those three things into account, the underlying risk for the child, what's going on in the community, and what the school is doing, then I think those decisions can really be better individualized.
Go to the next slide. Don, can you speak to, is there any guidance regarding returning to school related to specific immunosuppressive medications?
So that was a really great overview by Kevin. So I don't really have that much more to add because I think he really touched on it. I mean, again, just given the paucity of data, we just really didn't think we had enough evidence to really provide guidance related to any specific disease or any specific medication. Again, we were somewhat reassured that we didn't find any evidence to suggest that our patients with rheumatic disease, either on or off our traditional immunosuppressive medications, are at higher risk, at least from what has been published so far, with the exception of what has been described with the steroids. So we were reassured by that, but certainly, again, just as Kevin mentioned, there's so many factors that need to go into the question for each patient, and including, their disease and their individual characteristics, if they have other comorbidities or listed risk factors, how active their disease is, what medications they're on, if they're going up on their medications or down on their medications. And again, as he mentioned, sort of local school guidance and what their regulations are, and what's the community spread at the time.
David, can you let us know if there are any questions?
Sure. So one that is interesting, I think, is the question of whether obesity itself has sort of come out as a comorbidity for severe SARS-CoV-2 infection in children as it has in adults.
Sarah, do you want to take that one?
Sure, I see that Kevin just was about to chime in also. So we did consider comorbidities with the pediatric rheumatic diseases, but we didn't divide them up into specific comorbidities, specifically looking at obesity or other underlying diseases. So we didn't look at that specifically within the scope of our guidelines, but I think that has been found to be the case in general for children without pediatric rheumatic diseases and their risk of more severe disease.
Kevin, do you want to jump in?
Yeah, I agree with that. I think that there are a number of comorbidities that have sort of been identified in children in general. Obesity is certainly one of them, diabetes, heart disease, underlying lung disease. But it's hard to tease those out from some of the other conditions that many of those children have. And I don't think any of these comorbidities have been specifically identified amongst rheumatic disease patients.
And I don't see any other sort of specific questions. There's sort of an ongoing dialogue about, what is really safe, right now, and what we ought to think about doing in the next couple of weeks as the pandemic rages in many parts of this country. I'd also say that there is another task force of the ACR Executive Committee, the Practice and Advocacy Task Force. They're the only one that hasn't had a town hall, but they've got tons and tons of guidance documents up on the ACR COVID-19 website. And there's one document that speaks specifically to, sort of going back to work, to school, patients coming into clinic, and addresses a lot of these things. So if people want to find another take on this, and again, some of the same things that Kevin went through: community spread, what's your risk, is your school offering remote learning the same way they might be their parents' employer is offering work from home. So all those things that you can sort of take into consideration and then apply to a given patient.
I just want to address actually Nora's comment. I know it's not a technical question, but just with regards to TNF inhibitors, I know there's some more recent data suggesting that in the global registry that they were almost protective with the TNF inhibitors. So we, at the time of us, doing our evidence report, that data wasn't initially out yet, but and of course we are looking for additional data to help support those findings ongoing, but we are planning to revise these documents, as Jay said earlier on, that the whole goal of these guidance statements is to help sort of provide live guidance, but understanding that our information and our understanding is evolving, and that we certainly will have to go back and modify the recommendations based on the available evidence that comes out.
I want to go to the next slide. All right. Sarah, can you address, should children with pediatric rheumatic disease and other risk factors such as type 1 diabetes or end-stage renal disease be considered higher risk, and how should they be treated differently?
Sure. So I think we've touched on this a little bit, and Kevin has as well. The guidance document was developed with children sort of with typical pediatric rheumatic disease in mind. We certainly recognize that many children with rheumatic disease have comorbidities, either associated with their primary disease or independent. But really, due to lack of data regarding whether there is an additive or synergistic risk to multiple conditions, we really suggest that these patients, talk directly with their providers about whether they should be taking any additional risks to avoid exposure, or if they should be taking any additional measures if they have been exposed or are infected. So we really have a lack of data in this area to provide more specific recommendations.
Don, can you address any additional recommendations for children with pediatric rheumatic disease receiving infusions?
So our task force had several discussions about the various medications that are administered via infusions for children with pediatric rheumatic disease. And as was stated, we emphasized the importance of controlling the underlying disease. So we came to consensus that infusions such as rituximab or cyclophosphamide could be given, or maybe given sort of in the setting of severe rheumatic disease, whether it was life-threatening disease or organ-threatening disease, where there was a scenario where the benefits of treatment would likely outweigh the potential risks. The exception to this, again, was in a setting of an active COVID-19 symptomatic infection, where certainly we would temporarily delay the infusion if possible. Other considerations that might come up with regards to infusions or any infusions is just coming to the hospital for infusions. So I know that in our center, this was really particularly a problem in patients who rely on public transportation to get to the hospital. and particularly in March and April when we had an enormous amount of community transmission. So in those scenarios, certainly considering home infusions or considering transitions to oral medications, if appropriate to control the disease, might be considered.
David, any other questions in the chat?
No, not really. I'll just sort of speak a little bit to that, to the last point. You know, our colleagues in infectious disease came up with some guidance about testing people before they get infusions, and the adult task force questioned whether that was necessary. So there has been a deliberation between some of the members of the adult task force and the group from the IDSA, and I think the infectious disease group is going to revise their recommendations and not require testing for COVID-19 prior to infusions, which makes a lot of sense. But and I don't see. Well, there's a question on restarting immunosuppressive medications if they were held during the acute COVID-19 infection. What's the timing of that? Again, something that the adults just came up, the adult task force just came up with. So if anybody has any thoughts about that for pediatric cases.
Dawn or any other panelists have any thoughts?
So I don't know if Kevin would have thoughts on this too, because I know we did discuss this a little bit during our conversations. I don't know if it's entirely clear. I mean, I think in many scenarios, people are talking about whether it's a week or 10 days or 2 weeks after the fevers go away, or times where people are considered lower risk. But again, I don't know if there's been a clearly defined time point where we say that the risk is minimal. I don't know, Kevin, you have other more specific guidance?
No, I think that's generally the right time frame. I think we're not seeing a lot of relapsing COVID, symptomatic acute COVID. So I think that when their initial infection has started to resolve and they're a week, or potentially a little longer out from their resolution of symptoms, then they're in a safe period to restart.
Mindy, can you discuss ongoing treatment with tofacitinib in children with pediatric rheumatic disease in the context of the COVID-19 pandemic?
Yeah, so we didn't really address this specifically, or we didn't break it out specifically. I think there just wasn't the data at the time. I think, as Scott had alluded to earlier, there's more and more accumulating evidence that the JAK inhibitors can be helpful for that hyperinflammatory response in COVID infection. But certainly, I think you have to weigh that against the fact that these inhibitors also affect the same cytokine panel pathways that are very important for the antiviral response. So for us, we thought that reasonable to continue in kids without infection, but we had recommended holding in the context of symptomatic infection. And that too may change, similar to the situation with the TNF inhibitors as we get more data. And similar with the TNF inhibitors too, although we had felt that it was likely safe to continue them, we just couldn't think of any other infectious context where you would have a diagnosed infection and not stop immunosuppression if you could. But again, this is going to continue to undergo revision.
I don't believe there are any other questions. If anyone has any last minute questions, because this is our last Q&A slide. Otherwise, we will move on to our closing slides. I really want to thank our pediatric rheumatology clinical guidance panelists, Dr. Wahezi, Dr. Downs, Dr. Lo, and Dr. Ringold, especially for your hard work on the task force. So in terms of next steps, as we mentioned at the outset, these are living guidance documents. We will be making updates to these. We will update the topics that we already addressed based on evidence that comes out. but some things that weren't included in the initial guidance documents that we may be addressing. So development of MIS-C case definition once we get some data on the sensitivity and specificity of the clinical features of MIS-C, further clarification of the biologic basis of MIS-C and looking at some biomarkers for diagnosis, for risk stratification and treatment, the role of antibody testing, guidance specific to vaccinations. We brought this up but chose not to tackle this. And then we have thought about whether other specialties should be included on the task force, so specifically a neurologist or an emergency room physician. So thank you to the ACR for sponsoring this work. The ACR has a ton of resources on their website related to COVID-19. Really want to thank the pediatric rheumatology community for your questions and engagement this evening. Special thank you to their panelists again. Our goal has been to assist the community, the pediatric rheumatology community, with clinical recommendations during this pandemic. As David had mentioned, there's a second task force, the Practice and Advocacy Task Force, which has developed resources to help our members address things like the hydroxychloroquine shortage, to provide support for telehealth, information about federal stimulus relief aid, and guidance for infusions. And you can get access to all of these documents on the ACR website at www.rheumatology.org. And just as a reminder, the papers are accessible on the ANR website. Thank you for everyone that participated in the town hall. If you have any other questions, please email the ACR at covid@rheumatology.org. There was a recording made of this town hall, and it should be on the ACR website by the end of the day tomorrow. Thank you and good night.